Chapter 8. This chapter will help us describe the components of the communication process among the nurse to patient. We're going to compare effective communication techniques and identify blocks or barriers in communication. I hope to convey how important communication is, both verbal and nonverbal communication. So it starts with a channel, if you will. A channel starting from nurse as the sender. We send the patient a bit of information at the bedside when we hand them the call lights, because we never leave a patient without handing them a call light. Their way to communicate with us their needs. From the patient receiving the information, the feedback is them pressing the button so you'll come. And you agree. And it goes in a continuous circle. How we communicate verbally is how we talk to patients or how words are written. Your nonverbal communication, or those without words, is facial expression, body positioning, gestures, and appearance. If we are talking in front of a patient, our feet should be facing them. If we are talking to a patient and our mind is on another task, you'll find your feet facing towards the way you want to go, which is out the door. That is non-verbal communication. Not a good thing to do. If you're talking to someone, your feet should be facing where you're talking to, not away, because your brain has already decided, yeah, gotta go, I want to leave, and your feet will point you that way. Even though you may be looking at your patient, your mind really isn't there. So you need to be aware of that. But what can affect communication? Our cultures, past experiences, our emotional state, our moods, perceptions of people, right? Judging a book by its cover, you've heard that. Self-concept. Yeah, your self-esteem as well. Different cultures talk to people differently. You notice some cultures approach people by saying sir or madam or ma'am. Some people say hey. In nursing, hey is not acceptable. You greet your patient with the utmost respect. You identify them using their two patient identifiers, name, date of birth. Providing them with positive feedback as well when you start the channel of communication. Cultural nursing is among one of the most significant communication tools and or barriers. Research shows that people of the Hispanic culture like to avert the eyes or not make eye contact with you. It is a sign of respect from that specific culture. So the goal is that we need to be prepared as nurses to communicate with these type of patients or people who don't understand English. Facilities that accept Medicare, Medicaid are legally required to provide language services to all patients, no matter if it's a written language deficit, spoken language, or if it needs to be communicated with American Sign Language. An interpreter must be provided. You can observe a patient's nonverbal behavior by reading some of their cues, the anxiety, fear, pain. We often express No, you can see it in people's behavior and the tone of their voice, their eyes, their appearance, their body gestures. And how we interpret communication depends on personal and cultural values, education level, occupation, experiences that you've had through your life. We need to learn to be mindful, highly aware and alert of each individual's style and needs. This is the essence of nursing. If we cannot get our patients to trust us, build a rapport with our patients, do you think they're going to communicate effectively with you? No, they won't be able to convey their symptoms. You might be able to see their signs, but how they perceive their symptoms of a disease process is what you need to know. That is through communication. Okay, when we're talking about having a conversation with your patients or even having an interpreter, ideally you want to be 18 inches to 4 feet away from the individual to provide them personal space. This is speaking of their bubble, right? We don't need to be 1 inch away from their face or their body to understand what they're saying. We need to sit with them eye level, at least, again, a little over a foot to 4 feet away from them. If you're further away, you're going to create a space barrier, which is a problem because people hard of hearing may want to read your lips, and they might not be able to see you that far away. Okay. Now, you got a couple cultures, American Indians, Northern Europeans, Asians, that maintain more distance than Hispanic, Southern Europe, or Middle Eastern people. You'll notice certain people of culture like to get right up in your face and start talking to you. That's okay. Just maintain some professional distance. Again, 18 inches to 4 feet away. Let's see. Now, if you're talking to a patient of Middle Eastern descent, let's say you have a female patient of Middle Eastern questions, you might not get an answer until the male arrives, because the male will do the speaking for the female in this culture. Okay, Hispanics, they may wait for a friend or some sort of familial support before they start talking to you. Not always the case, but you may see this. Back to mood and environment. The emotions, mood, and environment can affect the way messages are sent or interpreted. Somebody that is suffering from high anxiety may not really hear what you're saying or interpret the message differently. Same goes with the depressed person. They tend to hear few words. And think about one time you've been upset. When you're upset and you have to communicate, you normally talk in a loud, harsh tone, which could be interpreted as abrupt. Keep this in mind when your patients are hospitalized or in rehab in a long-term care. They may be sleep deprived. They may miss their home, their pets, their family. All this has to be taken into consideration and never take it personally. We need to keep patients comfortable. We need to keep their mood neutralized. We need to communicate clearly and frequently. We need to obtain their feedback. That way we can reduce the amount of misunderstandings. If we understand our communication points, key terms, we're going to be able to effectively communicate. Next one is one of my favorite ones, active listening. This requires a lot of energy focus. Okay, this requires somebody who is aware of their own biases, their own energy level, they're aware of their posture, of their environment around them, their surroundings. This person utilizes listening for feelings as well as words. When you actively listen to somebody, you can gain or understand their mood or affect by simply closing your mouth and listening. And I'll tell you something, the patients really don't care about the experiences or struggles that you have went through. When they're in time of crisis, they only care about themselves. Minimize your stories to them, unless appropriate, of course. But we do not need to make the conversation about us. It is about them. Nursing is a selfless profession. Okay? Nursing literally is done from the heart in a selfless manner. When you're actively listening, you maintain eye contact without staring. You need to be aware of your facial expressions. Don't laugh at something that causes them pain because you may think it's humorous at the time. You make a conscious effort to block out distractions. Okay? Responding to the content and feelings of the message by stating what you, as the listener, understand by what was said. You look at their nonverbal cues. Listening, when you're actively listening, typically you're leaning forward, focusing on the face. You nod slightly. Somebody who's just sitting there like constantly going, yeah, 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 nodding their head like 100 times, that typically means that they don't understand or not focus on what's going on. When we see people just nodding their head up, forward and back, up and down, that means that they really don't understand. A few nods here and there is okay, but continuous, not okay. By doing this, this indicates that the patient's message is being heard, and you need to maintain open body posture, meaning don't cross your arms and your legs, don't look standoffish, don't fold your arms in and sit back like totally leaning back, almost laying down in the chair. No, sit up straight, like your mom taught you. Okay? Talked about this. Obtaining the feedback, meaning you're listening to what they said, and you're basically going to interpret in the way the speaker meant it. And ideally, you want to summarize. Somebody saying, listen, my head is pounding. It hurts in the back of my head. I don't know what happened. I've got a pounding headache. And I think it's because my son is stressing me out. I'm watching all my grandkids. I just can't take it no more. And you're sitting and actively listening. You're not speaking. You're listening with your ears and your body, right? And you're going to say, so let me rephrase this. Let me understand you better. You're frustrated at your son because of all the time you spend watching your grandkids, which that stress brings on headaches. Is that right? And they're going to say yes, because you've basically rephrased it and from their feedback. When you're focusing, now how can you focus and try to maintain time management? Keeping the patient on the conversation, meaning if they're telling you that they're getting headaches from stress at home, and then they start talking about where they were born and that it was the middle of World War II, we've just now got off on a tangent. Okay, bring them back to the original conversation, because if not, you're going to be there for hours. How can you adjust style? If the patient is a slower talking person, you need to adjust yourself to the pace and allow plenty of time for you to consider what they said and for you to elicit a response. A good way to bring this into real life. I had a patient from the Deep South. They spoke in a very slow monotone. Well, now, one day I was out on my farm and I put my foot right up inside this tractor and she just done cut off. That's why I ain't got a foot. Right? But then I have patients that come from New York. They're like, hey, I was emptying the garbage can one day and then all of a sudden, boom, bang, I lost a finger. Okay? Adjust yourself to understanding how they're talking. Adjust yourself to understand where they're coming from. You can adjust the pace by allowing for time or a short period of time because they're just going to get right to the point. Therapeutic communication. What we do best as nurses. Okay? We restate the message. We focus on the patient's needs. We promote understanding between you, the sender, and the patient, the receiver. We utilize verbal and nonverbal cues. These techniques should be used simultaneously. Okay? What we call therapeutic touch, we'll talk about in a later chapter. Some of these techniques, summarizing, encouraging elaboration. How can we encourage elaboration? Would we ask a question that elicits a yes or no response? Hey, does your foot hurt? Yes. Well, that's a yes or no question. That is a closed-ended question. An open-ended question would be, can you tell me a little more about your pain in your foot? That is an open-ended question. It leaves room for a story from the patient. Okay. Offering yourself to hear them, listen to them. Okay. Giving information to calm them and get them through their experience in healthcare. Here's what we don't do. We don't give advice. We do not get defensive. Do not ask prying or probing questions. That's why we ask open-ended. If they want to tell us, they will. Don't use cliches. Oh, this too shall pass. Right? Don't use cliches, which are common summarizations that have been used forever and ever and ever. If you're not listening to them attentively, right? Never offer false reassurance. A terminally ill cancer patient does not want to hear, oh, it'll all be okay. No, it's not. They're dying. Okay? Don't give them false reassurance and don't change the subject. If they're on it, stay with it. During nursing care. Let me see if I can finish this. I'm so sorry, guys. Well, I'm going to continue, even though this is not agreeing with changing the slides. Therapeutic communication techniques. When I say offer self, that means you're telling the patient, I'm here to listen. Can I help you in some way? Restating the question, if the patient says, I tossed and turned all night, you restate and say, so you feel like you were awake all night, right? General leading questions. It encourages the patient to continue to elaborate on that open-ended question. You can say, go on. I see. Please continue. Don't just say, yeah. Come on. Right? Well, what about, let's see here. We talked about restating. The purpose of restating is to encourage the patient to continue with information on the topic. Restating and reflection should be used very skillfully. If you continuously use it, they're going to feel like you're annoying because you're just going to use that way too much and that you're just repeating what they're saying, that you're really not paying attention to them. So it's definitely, that's really a skill. And then clarifying, because patients will say sometimes like 6 or 7 sentences just to say, yeah, the coffee kept me up all night, right? Then you're like, okay, by drinking coffee, it was the caffeine that prevented you to sleep, right? Clarify what they mean. We talked about therapeutic touch. This is used to signify support for the person when appropriate words are hard to find. You must take into consideration their culture, their feelings about being touched by a stranger. Okay? If I have given my patients hugs, and I'm like, you know, every time I hug a patient, I say, I just want to give you, is that okay? Can I give you a hug? Is that, and so sometimes they'll say, no, no, no. Other times they'll embrace it with open arms, literally. If they say no, respect it. Move on. You didn't do anything wrong. Okay? Just try to consider how they're going to associate a therapeutic touch with their needs, with their cultural views, right? Let's see. How can we solve problems? We are the problem solvers. Our essence is looking at different alternatives. Asking the patient, have you thought of your options? What might be possible solutions? Sometimes you can help them realize an answer to their question without even answering it. We are resourceful, to say the least. Okay. Again, in chapter 8, there's some tables that you'll find some excellent communication tips in some of the blue boxes. Table 8.2 has some great examples in here. How do you improve all these things that you're learning? You got to practice it. Start with your family. Start with your kids. Start with your significant other or your dog. Don't yell at the dog when he's scratching at the door. Do you need to go out? Okay, let's go outside, right? But practice makes perfect, okay? We don't give advice. We don't give advice because then you're shifting the focus on the nurse rather than the patient. And don't use the phrases, well, why don't you? Or when this happened to me, this is what I did. You need to rephrase to help the patient explore alternatives. Have you considered? You may want to think about, or have you thought about your options, right? Using cliches, like I was saying, some of them were, it'll be fine, or don't worry, it'll be okay. Yeah, they have to worry. They're a hospice patient. Hello. Okay. And how do you build a rapport with the patient? That comes from your interviewing skills, which we are going to have an exercise on that to help you establish a rapport with your patients, right? Obtaining a health history. You can take control of that interaction. You're initially going to ask closed questions because you need the data, specifics. Do you have insurance? Yes or no? Do you have a living will? That's a yes or no question. Have you been hospitalized in the last 30 days? Yes or no? We need the data. We need to ask it. Do you have any allergies? Right? What medications are you taking? After you get the health history of a patient during your initial data collection, that's when you can start with the open-ended question about the qualitative data, meaning how they feel. What brought you in today? What are your concerns about your hospitalization? Okay. A brief summary to get you out of the room. I think I have the information I need. Helps you close the interview and get out because you got other patients to take care of, right? Don't just say, can you stop? Can you? Yeah, that's good. Yep, done. No, Keep it professional. I think I have the information I need. Thank you. Leave them with a call light, bed in the lowest position, rails up depending on facility protocol. Do they have their items close by them? And boom, out. Okay. Again, considerations for the aging adult, the older adult, the elderly patient. You may have to redirect the interaction frequently if the patient focuses too long on one illness, one hospitalization, or one part of their life, because they're going to tell you their life story. Now, when you're gaining a relationship amongst your patient, the nurse-patient relationship, you are the helping role rather than the social role. You need to build trust, okay? With trust, they're going to focus on what you're saying and trust you. You can use empathy, the ability to understand the situation from somebody else's perspective, right? This is where you honestly have a desire to help in a non-judgmental way, with respect and genius. Again, we don't use sympathy in nursing, we use empathy in nursing. This is the ability to place yourself in another's position. You're non-judgmental. We don't care if we're caring for the janitor or the CEO. Doesn't matter to me. You're getting the same nursing care. Evidence-based. What we do, right? Somebody with heart failure, I would anticipate certain types of medicines. Whether they're a janitor or a CEO, that's what they're getting. Okay. Probably one of the hardest things to do in your evolution of nursing, okay, is becoming non-judgmental. How can you put away your own biases to successfully take care of a patient? Okay. This becomes easy to do when you accept people as they are, if you can truly see things from their perspective, because we come from all different types of background. You have to reference their values rather your own. Change your hat. If you're taking care of a Jehovah's Witness patient in one room, you put the Jehovah's Witness hat on. If you're taking care of a Baptist patient in the other room, switch your hat and put that one on. Doesn't change you as a person. You're just able to relate yourself to them, but not changing who you are as a person. You see, you turn yourself off and turn yourself on as the nurse. Okay. You need to emulate all that is hope in nursing, meaning hope is what helps a patient cope in a difficult situation. Okay? You're going to help them establish realistic hopes. The dying patient can hope for less pain, peace, a pleasant moment, a good laugh. A cancer patient can hope for a positive prognosis, a healing outcome, surgery. Okay? This is not where we never sugarcoat anything, right? But we can provide them hope. The patient I've had patients that have bowel surgeries, and they're scared that they're going to die during anesthesia with surgery. And you tell them, you're going to go in there, and they're going to help you. The doctor, they're going to talk to you. You're going to be aware of the pros and the cons when they come see you before the surgery. I'll be right here for you. Okay? The little things. We cannot promise that. I don't know that they're not going to die on the operating table. I can't give them false reassurance saying, I'll see you when you get back. No. Don't do that to them. Okay? Now, you may have some patients with problems communicating or altered communication ability. your nursing process still comes into play. You need to plan. If anything, planning is probably the most important way of communication. Communication, okay? We need to tell the truth at all times, okay? We provide patient-centered care versus saying, well, the doctor knows best. No, I know my body best. I've only been in it X amount of years, you know? Patient-centered care. Include them in their care. How do you communicate with somebody hearing impaired? Right? You need to face the person directly. Don't cover your mouth. Speak slowly. You may have to drop your mask down so they can see your lips, depending on facility protocol nowadays. Do not shout at the hearing impaired patient. Get close to their ear and speak in a solid voice. Not yelling, okay? But again, not directly into their ear. Close, about 2 feet away, right? Try to rephrase what you're saying in a smaller pattern if they can't understand you. Give them time, okay? You may take care of a stroke patient with aphasia, meaning difficulty to express or understand their language. This requires special nursing intervention, okay? This is from a neurologic damage from either a stroke or a head injury. You're going to need the speech therapist to help you on this one to determine methods how to facilitate communication. Sometimes a white erase board is handy for aphasic patients who can write. A piece of paper, okay? Drawings. Sometimes you can use a laminated communication box with pictures on it, like to eat, or bathroom, or change the channel, or turn the volume up. It's pictures they'll point to if they can't talk. If you have a... Hang on. Computer's giving me a lot of problems today. Normally it doesn't happen. Okay, so communicating with the aphasic patient. Okay, don't act as if they're mentally incompetent, because they're probably not, unless they're deemed incapacitated. But even then, speak to them with dignity. Speak to them with respect. If you need to repeat something, don't change what you're saying. Use the same words. If there is still difficulty after you try that, then you can rephrase what you said. You can use body language, drawings, gestures, facial expression. Allow one person to speak at a time. And downplay the errors. Celebrate their ability to speak. And don't be overprotective of them. Don't just say, "Oh no, don't go ask her. She can't answer. I can answer for you." No. You're not the hero. Let them, we need to try to get them back to optimal health. Meaning, let's promote communication amongst them. Okay? When you're talking to aphasic patients or trying to communicate, you need to make sure your environment is relaxed and quiet, so there's no distractions. Typically, you want to phrase your questions to be yes or no. Are you thirsty? Yes or no, right? All right, so continuing on with communicating with the older adult, key term, don't rush. Wait for them to answer one question before asking another. Don't finish the sentence for them. It can be very frustrating, guys, when you're trying to communicate with an older adult and they take a long time to answer, but you can't get frustrated, okay? You can't get frustrated. Now, if you're communicating with kids, consider the influence of development on language and thought process. They may be more responsive with nonverbal messages. They could become frightened with sudden movements or gestures. Kids, you got to approach them at eye level by sitting or kneeling. You got to use a really calm, friendly voice, right? When you're interacting with the infant, keep the mother within the baby's view. A preschooler or a toddler, focus on the child's needs or concerns. Simple short sentences, right? This goes along with Erickson's developmental stages, which you will learn in pediatrics. Okay. Sometimes you may find out that some cultures with older adults are not accustomed to taking instructions from somebody younger than them. You might have to have a family member that's able to know the case, right? That's like the healthcare advocate, and you might have to provide printed materials in their language. Remember, if they don't speak English, you get an interpreter. Now, how do you communicate with the healthcare team, right? Well, this is shift report. This is getting reports, meaning labs, radiology, different modalities, meaning different departments have their own tools for communication. This is when you have a patient that's leaving the unit and they're at risk for falls, you need to convey that to the transporter. If they're a DNR, if they're a full code, you need to convey that. Walking rounds, your end of shift report, right? This is when you got reports going from given as nurses from the ongoing or ongoing shifts, room to room. Walking rounds, let me paint a better picture. Let's say you got the nurse from day shift and the nurse from night shift, and then maybe the charge nurse from day shift, and then maybe the physician that's going to be taking the case on during the day, and you walk from room to room. Those can be known as walking rounds. And this helps you get the full report on the patient. It normally takes about 1 to 3 minutes. It takes practice to give a logical S-bar, okay, meaning situation, background, assessment, recommendation, and you can include readback or the cue questions when you have to do bedside shift report. And that is how you're going to communicate. And we will work on this as an activity. Telephoning primary care's orders. We do not like telephone orders. We want them to use CPOE, computerized provider, not nurse, provider order entry. CPOE, that's where the doctor puts in their own orders and you don't have to take it and transcribe it, okay? As students, you cannot legally take telephone orders. You must give it to the RN, okay, who's on there. Now, how can you take your assignment into consideration? Delegation is one way. Do not delegate what you can't eat. Evaluate, assess, or teach. Okay? That's a good rule of thumb. If you're telling a CNA, hey, let me know when they have a fever. Well, a fever to a CNA versus a fever to a nurse, you need to tell the CNA, hey, can you let me know if the temperature for Mr. Johnson in room 102, if his temperature goes above 101.2, okay? And then you say, they're going to say, okay, thanks. And you're going to say, hey, can you just summarize what I said? And they're going to say, yeah, you said go to see Johnson, check his vital signs, let you know if the temp is above 101.2. That's it. You get a read back, you get a return of the feedback, and now you can delegate that legally and ethically. Okay. Computer communication. This transmits requests from like the lab, dietary, radiology, PT, RT, different modalities. This helps orders to be communicated to the nurse. Maybe you get an order from pharmacy to add a new medicine that's going to go to your MAR, your medication administration record, right? You know, in a lot of agency, they give you a handheld computer like a tablet, so you can input or put in information like vital sign, document your data collection, record your observations, right? So again, computers and technology skills are essential for the nurses of today. You can, JCO, or Joint Commission, has historically stated that you can't text medication orders. Guess what? In 2016, they revised it, allowing texting patient orders under specific guidelines like secure sign-ons or encryptions. So we've, it's came a long way as far as communications. I think CPOE is the greatest thing. Again, allows orders to be electronically placed directly in the patient's record. Let's see here. The other types of orders are written orders and verbal orders. Verbal orders, you have to repeat back and get confirmation. So doctor says, yeah, I need you to give a stat dose of IV Lasix 40 milligrams now. You're going to say, okay, so you would like me to give a stat order of Lasix 40 milligrams IV now. Yes, that's it. You don't just listen to what they say and say, okay, yes, doctor, thank you. You have to repeat it back. Okay. One special alert is you have to be aware of exchanging telephone information, and that's where you follow the ISBAR format. You introduce yourself, including your unit, verify the name, background, report the patient's current condition, listen to the order, write it down, and read it back so we can ensure accuracy. Let's see. All right, that's what I have for Chapter 8.